Jennifer? All righty. Do you see the community health needs assessment? Or you just see my desktop?
No, not yet. Just your desktop.
Okay. That means I have to move this over. Okay. Can you see it now?
Yes.
Yes.
Okay. Let me see if I can do it. Okay. So the community health needs assessment was completed back in 2019 for our 3-year cycle. And as you can see, this is a tri-county assessment plan. So it includes Peoria, Tazewell, and Woodford County. And the reason that we do this is because our health systems, which is primarily OSF, Unity Point, and Broman, this is kind of their patient/client area, right? So residents for those 3 counties are, they're the hospital patients and clients. So we've taken a regional approach into doing this. So this is, and this will be available, this is available on the Partnership for a Healthy Community website. And all you need to do is just Google Partnership for a Healthy Community and then go to the website, and it'll have all of our needs assessments for the past probably 3 or 4 cycles. And our community health improvement plan is located there, along with the annual reports that shows what the work that we've done and our outcomes from our interventions. So this is the table of contents. Again, it's going to be a very high level overview. I'm not going to do a deep dive, but I want you to understand what the process is of how we arrive at our health priorities for our community. So from the table of contents is sectioned in the actual methods. So there's demographic profiles of our community by various categories. And then the second chapter is more on the prevention behaviors based on like the health status, understanding food insecurity, wellness, kind of like the generalized topic areas of prevention. And then symptoms, and then getting into the actual chronic disease assessments, as you can see. And then the final chapter looks at just kind of coagulating and synthesizing the data to identify what the priority health needs are for our community. So as I said, this is a collaborative effort. It's under the name Partnership for a Healthy Community. This is an emergent organization. It started just more like a coalition of the health departments and the health systems. Now it's more of a cross-sector approach where we have representatives from social service agencies, from the business community, and other sectors. We're formed into a formal 501c3, meaning we're a not-for-profit organization, but our priority mission as an organization is the development of this needs assessment and the health improvement plan. Now, just on the side note, our health systems are required to produce this document to maintain their 501c3 status. So for our health systems to retain as a non-for-profit entity, they are required to have this document completed within a 3-year cycle. So that is their motivation to continue to participate in this as well. But there's, multiple benefits from us taking a collaborative approach to identify our assessments and our needs, and you'll see that. So very high level, and we'll get into how we arrived to this, but the 4 health priorities is healthy eating, active living, and that's defined as active living and healthy eating and the impact on obesity and access to food and food insecurity. Cancer, in this context, is defined as breast, lung, and colorectal cancer screenings. And mental health, defined as depression, anxiety, and the ultimate suicide. And then substance use, and that's defined as abuse of illegal and legal drugs, alcohol, and tobacco and vaping use. So this is how the partnership is structured. This is the org structure. There's a governing board, and then there is a data team that works to do a community health survey that is distributed throughout the entire Tri-County region, and we work with our partners to get that information. They are also look at the health systems data, for example, like Epic, and all of the screenings that you have in your Epic system and all that data that's collected. And there's also other data from the federally qualified health centers that they use. So there's a whole myriad of data that is collected. And then there's a collaborative team that kind of helps organize everything. And from thence, once we are ready to prepare our community health improvement plan, there is action committees that is formed to go over the strategies and objectives, and they're responsible for meeting those evidence-based strategies. And you'll see it, the formation and the flow as we go through it. So these are all action committees that you see here, okay? And these are more of like our community committees. So if there's a church that has, a ministry for, substance use counseling or education, they can serve on this committee with the health system. So these are our community action committees. So that's how we're formed, and it helps us to strategically prioritize our health priorities, right, and have a consensus and a shared goal for our community. Okay, so this is just showing you how that data that I talked about is collected. Yes.
Is it possible to make the font a little larger, maybe zoom or something like that? Like zoom in maybe?
Okay, let me get out of this. Now, there's ways you can make it larger, I think on your end too. Can you do like a full screen or something? Like, those three little buttons at the top that says more actions?
Yeah.
If you click on that, what happens if you hit full screen? But I'll get it off of this. Hold on 1 second. Get this off. Okay, I'm not sharing anymore. Okay, so I'll just open it up as a regular. I'll do my part here. Is that bigger?
Yeah, that's way better.
Okay. Did you hit the full screen?
I did, yes.
Did that help too?
Yeah, it did. Made it a little larger too.
Okay. All right. So we're good. Okay. So this is, again, the data process. So you have you all know what this means with the secondary data and primary data. That data is collected, and then there's an analysis and interpretation, statistical modeling. So again, there is a methodology and process to come up with the prioritization and the implementation. So just wanted you to see that. Okay. So we won't do a deep dive in that. Like I said, there's a survey. So there's, it's a validated survey. So there's a survey instrument design. And this is the components of it, the ratings for health issues, unhealthy behaviors, well-being, access to health care, So you all can look at that. We've also just now recently included intentionally social determinants of health to find out, what some of those barriers are to access to care and change of behaviors. Okay. So we are going to dive, all of this is demographic information that you can look at. So we're going to keep going and get to, so let's start here with choice of medical care, because you all are health practitioners and I'm sure you'll be working in a hospital setting. So, so this is the discovery on the accessibility of healthcare. So a question was asked to select the type of healthcare facility used when sick. And the data showed that the most common response was clinic and doctor's office, chosen by 74% of the respondents. Urgent care was second at 15%. Not seeking medical attention was at 8%, and emergency department at 2%, and the health department at 1%. So that's just a chart of what that looks like. So what I do want to point out, and this is the direction that we're starting to go into, is that we really want to start looking at collecting data from an equity lens as well. So looking at this, you see that, oh, okay, 74% of the survey respondents, like, wow, we're doing it, right? Majority of those that responded go to the clinic and doctors. However, when you put that equity lens on it, when you start doing that deeper dive into actual population health, right? So out of that 74%, how many, what's the percentage of people of color, or what's the percentage of those that live in the equity zip codes that actually have access to the clinic or doctor, or that is their choice of medical care. So, so that's the exercise that they went through and doing a deeper dive in the data for this cycle. So this is social determinants related to choice of medical care, right? So the following relationships were found using correlational analysis. So the clinic doctor's office tends to be used more often by older people. Again, we're doing a population health, by older people, those with higher education, and those with higher income. Clinic doctor's office tends to be used less often by Latino people and people with an unstable homeless housing environment. Urgent care is used more by younger people. The emergency department tends to be used more often by Black people, less educated people, those with lower incomes, Peoria County residents, again, breaking down that population, and people with an unstable housing environment. Emergency departments tend to be used less by white people as a primary source of health care. So again, just this, and I won't, go down into this, but the point is once you put that equity lens on these doctors and you get into the actual population health, it starts to tell a different story. 74%, that's the majority, but then when you break it down, you'll find out that this majority is more than likely, white people, older people, and those that have access, more immediate access to care. So those populations that are non-white, may be younger, where are they going? And then what are those barriers to care? And that's where our interventions and our strategies come in, because we have to follow that equity lens and be more targeted to reduce barriers and to improve access to care. So this is just an example of that. And And when you pull this document up, you can look through it, but it's the same kind of methodical equity process that we went through for every category. Again, it's, the survey results, and then here's the whole equity lens, right? So Medicare tends to be used by older people, men, Black people, Peoria County residents, and then Medicaid tends to be used more by Black people. So now, it's telling us this story, right? So when you're seeing your patients, now you kind of know, in addition to just this, your clinical therapies, now you're having more information about, one, their built environment, their ability to access, what type of insurance coverage that they are more than likely will have. So it's painting that story. So as you come up with your therapies and your interventions, we're trying to work with our clinicians to have that full overall built environment view of really what the patients are going through, and their environments and their mentalities and cultures, because all of that is important, right, for overall health. All right. So again, access, and I won't go, and you kind of starting to see the themes here, right, from a population perspective. So no need to go through all of that, but you can read it. So let's jump down. Food insecurity is like a priority for us. And even with that, right, healthy eating, consumptions of fruits and vegetables tends to be more likely for women, those with a higher level of education, those with higher income, and those with a stable housing environment. So if your patient is a man and with a lower level of education and lower level of income and unstable housing environment, you have an idea of maybe, why that person's diet is the way that it is. Okay. So again, so we'll get out of that because it just keeps going on and on. It's really good, rich data. So substance use is part of that too. So those are behaviors. So now, we're getting into the chronic disease section, right? So those are the various health categories. And then it talks about the importance of the measure. Like, why did we choose this measure, right? And it has the data to verify why these chronic diseases are even on our radar for consideration. So you all can look at that. So let's go down to the actual prioritization. Okay. All right. So now you got all the data, right? So what are we going to do with this data? So to go into the prioritization of that, there's specific criteria that was used. So they looked at the magnitude of that disease or behavior or access, the magnitude in the community, the severity in the community, and then the potential for impact. Okay. So again, this is a discovery of perceptions in the community, unhealthy behaviors. You can see drug abuse. It's at the top, poor eating habits, alcohol. So this is a real reflection of our community. These are your patients, right? This is the behaviors of the patients, okay? So this is data as far as how they're perceiving well-being. All right, let's get to, okay, so out of all that, 9 potential categories was selected. Okay, gun-related deaths was theirs as well. because of the exponential increase of mortality rates. So all our health departments, our surveillance data is also included in this data review, just so you know. So again, going back to that magnitude, seriousness, and effectiveness considerations, it's called the Hanlon method, and that's later on in a document if you want to know more about the Hanlon method that was used. But the data was reviewed based on this particular method, hence our health priorities, okay, that I mentioned when we first started. So let's just look at why, like, okay, just high level. So healthy eating, active living was selected because the number of people diagnosed with obesity and being overweight has increased from 2009 to 2014. So it's an upward trend. So our obesity rates is higher than state averages in all counties. And our rates, and then the survey respondents were asked to self-identify their health conditions, and over almost 40% in the community survey said they identified as being overweight or obese. And then active living was included in that because nutrition is part of it, but as clinicians, that nutrition should be coupled with regular physical activity as well, right? Balanced diet and physical activity. So they're married, they go hand in hand. And 33% of the residents said they may only exercise 1 to 2 times a week. And then the healthy eating, 60% reported no consumption or low consumptions of fruits and vegetables per day. So our residents aren't really they're not really eating fruits and vegetables daily, right? So if they're not eating fruits and vegetables daily, what are they eating? And we all know the answer to that. Probably processed, packaged, and fried foods. Okay, so that feeds into food insecurity, right? Because you can have access to food, but is it healthy, nutritious food for your body, right? And if it's not, you are food insecure. So again, that whole space, that's why that category was chosen. Excuse me. Cancer was the first or second leading cause of mortality in all 3 counties. Particularly breast, lung, and colorectal cancer are more prevalent in our region when compared with the state of Illinois. Okay, so again, that's more data. I won't do a deeper dive, but that data confirms the priority in our community. Again, with mental health, our survey respondents, a third of them said that they, experienced some form of depression or anxiety in the past 30 days. Also, with the youth survey, there's a youth survey that's done, and there's an increased feeling of sadness and hopelessness. And so, again, our survey respondents are telling us this. Half of them felt depressed. In the last 30. So again, this is like on the radar. There's high anxiety in our community, and then our suicide rates are increasing. Substance use, it's impairing our decision making. It's a response to trauma. So this all kind of goes into that, and then it's a growing rate of those that are actually, ODing from substance use as well. So that's why that made the radar. So again, high level, this is, how we're formed, how we collect data, how we do our assessments to come up with our health priorities. Okay. So now we have that document, right? Like, what do we do now that we know what is going on? So I actually wrote this document. So we work with our community partners collaboratively to develop our community health improvement plan, which is essentially like our marching orders collectively for the next 3 years. And as you can see, 2022, it got here so quickly, will be our final year in doing this. So we have actually just completed our community health needs assessment survey for our 2023 cycle. So we're going to go through that process again in 2022, and we'll go through high level how we created these documents. Okay. So table of contents, again, high level. We talk about the partnership. We have, we report on what we did the last cycle, some of our outcomes. And then we get into this current cycle, how we derived at our health priorities. So you see we have the data, and then we couple that with the goals, objectives, and strategies that are developed. Okay. Do you all have any questions so far? No questions? Okay. Yes.
You didn't mention the 501 status. I don't know if I missed your explanation. What does that like? What is it exactly?
Yes, so businesses have a operational status. So you could be a for-profit business, right? Which means that if you're for-profit, you have to pay, certain taxes to the government. But if you are a non-for-profit, your designation is a 501c3. So non-for-profit organizations are more mission-based. So churches, social service agencies, they're not in the business to make a profit. So they don't have products or services that they sell. They provide a service, and they're usually grant funded, right? But from a taxes standpoint, they don't say that they have geared a profit at the end of the year. So that's the same thing with health systems. Health systems are designated from a tax perspective, business perspective, as non-for-profit organizations. So that's called 501c3. So in order for them to keep that, where they don't have to fill out tax forms on, because it's a fee for service in hospitals, right?
Right.
There's insurance coverages. It's a business, right? But they don't have to tell the government that they've had a profit or a loss, because the income that they receive goes back into the organization for more services and more care, right? So they're not looking at, like corporations look at, a profit margin, right? Where our profit is, we got 200,000 every quarter as a profit after we pay all of our bills. So as a non-for-profit, if they do have that 200,000, they don't have to claim that as profit. They can say that 200,000 is going to go back into this organization for continued services. So this provides a protection for health systems to maintain a non-for-profit status. That's the business part of healthcare. So they are motivated to do that, right? So that line item at the end of the year, if it's $1 million left over after they pay all their bills, they don't have to have that as like capital gains for it to be taxed. So this incentivizes them. And actually, doctor, this is a very good point, that traditionally they did not have this needs assessment. It was through the Obama administration and the American Recovery Act that the administration wanted to ensure that the health systems were being intentional about working with community partners to come up with a health improvement plan that was accessible to community members. So that was their way of doing it. So this has only been a requirement since 2009. Okay. But as you can see, it has motivated our health systems to get organized. One, bring other partners to the table and work with our community. Two, start planning regionally. And then three, be accountable for service delivery to meet a collective goal or strategy. So all of this, so hence why the partnership is a newly formed now organization. So we're forming, it was all a ripple effect. It's been a ripple effect. So as a community, we're learning how to formally work together as well. Okay. So this is again that partnership. Remember, we talked about that formation. And as you can see, like in 2016, this is when they started with the collaborative approach. But now, we are more formed, we're organized as our own organization now, with the board members being representatives from our health systems and the health departments and other agencies. Okay. So that's that. And these are the board members, just so you know, like who's these members. This shows the cross-sector participation. So we got a health department, we got economic development, social service agency, wellness organizations. So again, we have all come together with the purpose. And then Dr. Simon, for the health department, we are also required to do a needs assessment. They created a state statute for health departments that we also have to produce this document. So our government agencies were intentional about us, being able to collaborate instead of us just saying it, right? Like, oh, we're gonna come together. Now, this is a motivator for us to be organized. You see, Bradley did that handling method. So the researchers at Bradley, excuse me, assisted in that. All right. So I won't go deep into it. This is the last cycle. The only difference was reproductive health. From our last cycle, we had high STD rates. And that was one of our health priorities, but it didn't make this current cycle. So you can look through this to see what we did. Those are some of our initiatives that we just highlighted. So you can look at that when you get a chance. Get yourself tested. All right. And again, this is the methodology of us being organized, that we're in this phase now. We want to cooperate, coordinate, collaborate, integrate. We did a SWOT analysis as a team, our action teams and our board, to see what our strengths, weaknesses, opportunities, and threats. So this is all strategic planning, right? Then the data team, which is a newly formed team as well. Again, we're being emergent, and we're working to see how can our health systems and health departments and FQHC, how can we start sharing data, right? Because we all got our data sets, we're siloed in data. So the formation of this team is to help us intentionally start seeing how we can, amongst ourselves, synthesize data and report out and create evidence-based strategies. The website that you're going to go to is new as well. So again, we're all in, our development journey and our evolution as an organization. So we do have a website now. So social determinants, I pulled this out contextually so the lay people that read this will understand when we're talking about social determinants and health equity, what are we really saying? What is it? What does that really mean? So I added that just so we can all have that same definition and that perspective when we're going through this document. So I'll let you all look at that when you at your leisure. So this is the overall summary that we just went through all of this for the community health needs assessment, right? That was our prioritization. And we did that. We came up magnitude. Remember those three components. Those at handling method, and it spit out our priorities. That's that. Um, this is how we looked at starting to formalize our strategies. So we do adopt evidence-based strategies. And Healthy People 2020, it gave us great direction on objectives and interventions that we could use that are already evidence-based. So again, we took all that information, we did summary data sheets, so everybody had it. And then in total, over 100 community members from various sectors participated in both planning process. So after we had that, we have action teams, like who wants to be on the cancer, colorectal cancer, action. I do. We got a program, where we're trying to, have market Cologuard out to the 61605 zip code. Okay, you're a committee member. So we got, that's how we did that. And we formed our committees. So the action teams, they came together with all this information and they created their pretty much their plan, their improvement plans for that health priority. And we'll go through one of those just so you can see what it looks like. So these are the goals, high level. Healthy eating was to foster and promote healthy eating and active living, to reduce chronic disease in the Tri-County area, reduce illness, improve mental health, reduce substance use, okay? So these are summary sheets from that I sent it. I tried to just, high level, because that needs assessment is very detailed. So I had to just take little components, for the lay people to give snapshots to verify the health priorities and the goals. Okay. So this is what they came up with. So this is a snapshot summary as well. Foster and promote healthy eating and active living. What are the objectives, right? Now we're getting into more evidence-based strategies. We're setting percentages based on our resources, our willingness to partner, and how we can measure it. So we're saying by next year now, reduce the proportion of adults considered obese by 2%, reduce the proportion of youth who self-report overweight and obese by 2%, and by 2022, decrease food insecurity. So this community health needs survey that has gone out, once that data gets synthesized, that will tell us if the self-reporting has gone up or gone down. So that's going to be some data that we can use for this particular cycle. So these are the strategies, like how are we going to get there, right? These are evidence-based, meaning that they've been proven to work. They've been validated, they've been measured, and they will have an impact based on your measurements, right? So breastfeeding promotion, family-based physical activity interventions, screen time, like turning that TV off for children and giving them alternatives, and food insecurity screening. So we did that. I won't go through all that, but I want to show you our work charts. So I worked with the group to create these charts, okay? And this is what because in our action committees, we have a regular meeting schedule, and our partners report back on their activities, and they also plan and organize. And if there's any grant opportunities, we'll collaborate on a grant. So it kind of gives us, puts it in perspective, right? And we have all adopted this plan. So now it's a part of our organization's operations plan and our strategic plan as well. So it's working out very good. So in this context, following that healthy eating and active living, right? That's that goal. And then the objective, this includes baseline, right? Because any objective that you're meeting or goal that you set, you know, you need a baseline to measure it to see if you've made any improvements. So the baseline we use for this is the percentage of adults considered obese, and this data was pulled from the county health rankings. So these are the percentage. We're all at kind of a third of our populations is considered obese. And then our strategies are based on social support. So we're pulling out now the strategies. And now we're saying how we're going to evaluate, right, these activities. So we're going to look at BMI. We're going to look at exercise days. Again, that needs assessment, right, that survey. And then the servings of fruits and vegetables on a typical day, that's that survey. And these are our partners, okay? So they are part of the Healthy Eating, Active Living Action Committee, all of these organizations. Again, we did, you know, it's another objective for youth, right? We talked about youth. They put breastfeeding in youth, I guess, because it's, you know, children and infants. But those are those interventions specifically for youth. And we're going to look at breastfeeding rates, fruits and veggies, hours per day. So the Illinois Youth Survey will give us that data. And then these are our partners. So again, you can look at food insecurity is real. We need to assess the level of food insecurity in our community to really know what we need, whether it's, do we need more grocery stores? Is the grocery stores the answer? Do we need more education on healthy foods and healthy food prep? So all of this is a discovery that this group is working on. They've created a food insecurity screening data. They've been going out to like the food pantries and the food banks and churches, and they're collecting data so we can get better, really baseline, deeper dive on the levels of our food insecurity, okay? So that's just an example, and I won't go through. We did the same exercise with cancer. And as you can see, again, the methodology is that baseline. Then you have to evaluate it. You have to have your partners and then your interventions. Okay. See, mental health. Okay. So, and then this is just kind of an abridged version of the needs assessment. If people, you know, because agencies use this to apply for grants in their own organizations as well. So I wanted this to be a document instead of them having to look at the needs assessment, read all this, like a one-stop shop for them to have everything that they need for, you know, grant writing purposes or for their leadership in their organizations. So that is where we are at. With all of that, are there any questions? Any comments?
No, it seems like thorough research or for like, and how they can like a big.
I'm sorry, you're breaking up, doctor.
Okay, sorry. Yeah.
Can you repeat that?
Can you hear me now?
Yes.
Okay. It seems like it's a very thoroughly like needs assessment that's been put together for the community. So it seems like it's a great resource, something important for us to make note of. I know that this is sometimes done in like other communities that like we were to practice in. Is that something that's done routinely? Like is it kind of shared amongst all hospital systems as well?
Yes, so every community is different, and this needs assessment is in itself is an approach for getting community health data. And so the surveys, the existing data instruments, how this data is synthesized in itself is a model and a process. Other communities get data, they have like dashboard information. They may just have a big community meeting to get information. So it's various levels of our communities gathering community health data. Okay. In the state, well, with the federal Obama administration, with that needs assessment, it is a requirement now. So health systems, in order for them, if they want to have that 501c3, then they're obligated to do that. I don't know if there's any health systems in the United States that are profit driven, but for our community particularly, they are non-for-profit. And so they are motivated to do this document. So like I said, it has served us well with this being mandatory. When they started, it was way more general. It was more just like, oh, you know, the health systems decided what data they wanted to share and how they wanted to share it. But now it's being more, data is a priority. And even one new thing that we do know is that, and I don't know if you all are, if you're using this tool that you have in Epic, there is a social determinants of health section in Epic. Are you both familiar with that, with your patient care? Okay. That is from this group. That is from the needs assessment. And we've been talking with the physicians, and you all been saying, you know, we only got, 10 minutes and we don't have time. That's a deeper dive and this, that. So we've just been encouraging, this is information that's important if we're going to be intentional about equity. It's collected, it tells a story. It's not just the health system resources, but it's other community resources that we want to target. So if you all can find a way to collect this data, whether it's with your nurse practitioners, they can do it. I don't know if it's the front line or, find creative ways to gather this information, because it's really telling a story. COVID has shed a light on the inequities. And I will tell you all this story before we leave. So we were talking with one physician, and she told us that one of her patients, she put him on 4 blood pressure meds. She could not control his blood pressure, and he was on up to 4 meds, and the BP still was not going down. So she was having conversations and everything, and he was, health literacy is real. So he wasn't really, disclosing everything. So she decided to do a home visit. She said, I'm going to do a home visit. So she called him and said, can I come to your apartment and talk with you? She said, I just wanted to see what was going on. She visited him, and his entire apartment had empty pickle juice bottles everywhere, jars rather. So he loved pickle juice, and he drank pickle juice all the time. Not the pickles, but the juice. So again, right, there is a reason why your patients, why some of these chronic diseases cannot be managed and is beyond, prescription or therapies. And we have to get to the point where we know the full story, so we can talk about, nutrition, or have referrals where he can, learn how to, if it's a pickle juice taste, where can he get that without all the sodium? And even having a conversation about pickle juice right now, she could talk to him where he's at, versus thinking that, I can fix this, and if I give him these prescriptions, it'll happen. So, this is all emergent, and we're going to keep these community conversations going. And the good news is that you all, as clinicians, you're not alone now. Now you have a team of practitioners in various sectors that is willing to help. So, but we need the data. We need data to drive that. So So that's my elevator speech on equity. So any other questions or comments, Dr. Simon? I can't pronounce, how do you pronounce your last name?
Kabtutwa.
Katuta?
Kabtutwa.
Kapatutwa. So
You
Dr.
nailed it.
Kapatutwa. Do you have any comments as well?
Yeah, not any different from what Dr. Estrada has said. And just make sure I'm understanding this correct. So across the country, all hospitals are now required to get involved with their community, and they have this same needs assessment for their communities where they serve
Yes,
at.
if they are operating their hospitals as a not-for-profit organization. There is various business statuses that organizations can operate in, and I'm not a business person, but for the 501c3 designation, which is a non-for-profit status category, our health systems, OSF and Unity Point and Broman, operate under a 501c3. So that's why they are doing this assessment. Now, across the United States, I don't know how other health systems are operating. They may have a 501c4 or something that's not required. But we know for 501c3 requirement, a needs assessment has to be done. So so that's kind of how that's at. And that's a good research question, right? How are other health systems formed? What type of business entity are they? But if it's a 501c3, there's going to be a document for some type of community health assessment. Now that assessment may or may not look like ours, because again, you see, we have a methodology that we've adopted. So, and there's various methodologies that are out there to collect data. Okay. All right, well, thank you all so much for your time. If you have any questions, again, you can go to the Partnership for a Healthy Community, just Google that, and it'll have all of this information and historical data for you, okay?
Okay.
All right, well, thank you all so much. You have a good day.
Thank
Thank
you.
you.
Bye-bye.